Majority of cases are symptomatic at presentation. When a lung cancer patient comes to our OPD, the staging workup starts from his complaints. The complaints can indicate that whether disease are local or it's an or whether there is an intrathoracic spread or the patient is presented with a distant mets. There are some definitions which was given by ACCP, American College of Chest Physician. They have defined these are basically CT scan findings. A solid pulmonary nodule, which will be a single well-circumscribed radiographic opacity that measures up to 3 centimeters in diameter, and it is completely surrounded by aerated lung, and there is no associated atelectasis, hilar enlargement, or pleural effusion. A lung mass is something which is a focal pulmonary lesion that is more than 3 centimeters in diameter. They are presumed to represent bronchogenic carcinoma until proven otherwise. Diffuse nodules, when the number of nodules are more than 10, they rarely represent a bronchogenic carcinoma and are usually due to metastasis from extrathoracic malignancies or active infection or inflammation. So there are some CT findings which indicates that a particular nodule or a mass is malignant one. If a nodule has a spiculated or ragged margins, the likelihood that it's a malignant mass is 5.5 times. If there is presence of pleural retraction, the likelihood is around 2. Presence of vessel sign, the likelihood would be around 1.7, or there is 70% higher chance that it's a malignant mass. If it's lobulated margins, it will be around 1.1. A true cavitation, especially when associated with a thick and regular wall, is a strong predictor of malignancy. While presence of bronchus signs and presence of smooth or polygonal margins are basically indicates towards a benign mass or lesion. Non-calcified nodules, they can be malignant or they can be benign. So it's a feeding vessel signs in our first diagram, where we can see a vessel is going into the mass, while a positive bronchus sign, where we can see a tubular area of hypoattenuated bronchus, hypoattenuation, which is basically a bronchus that leads directly into the peripheral pulmonary nodule. So whenever a patient presents with a new solid indeterminate nodules on chest, which is CT, which is 8 to 30 mm in size, we have to decide about the surgical risk, whether the risk is low to moderate or if it's a high risk. If it's low to moderate risk, then we have to decide what is the possibility of malignancy. If it's very low, CT surveillance is sufficient. But if it's low to moderate, then we need a PET, and then PET will decide whether surveillance or non-surgical biopsy is required. If it's high, again PET. If there is no metastasis, we can directly go to surgical resection, no biopsy required, or we can directly go to the Sbrt or RF. If it is high risk as per surgery, so we can either go for a non-surgical biopsy or we can go for a CT surveillance. So how to decide a surgical risk in a patient? So if a patient with a negative cardiac evaluation and with a predictive post of FEV1 and predictive post of DLCO more than 60 is considered to be a surgically low risk patient, where expected mortality after surgery is only 1%. While if it's less than, if the DLCO is less than 60%, predicted post of DLCO less than 60%, less than 30%, and FEV1 less than more than 30%, then it will be considered. Then we need a cardiopulmonary examination, cardiopulmonary exercise test. Exercise test usually includes exercise, monitoring of heart rate, and then deciding what amount of oxygen consumption a person is doing, and then according to that we decides VO2. If the VO2 of the patient is less than 10, he is high risk. High risk means the chances of mortality after surgery is 10% or more. Patient should be explained regarding the mortality, and alternative treatment options should be provided to the patient. What would be the probability of malignancy? How we decide probability of malignancy? So if we are doing clinical examination alone, if a patient is young, there is a very small or minimal smoking history, no prior cancer history, there is small nodule size, with the regular margins and it's a known upper lobe location, the chances of that lesion being malignant is less than 5%. Similarly, if the patient is old, he is a heavy smoker, he is having a history of prior cancer, the nodule or the mass is large in size, it has irregular speculated margins, and the location is upper lobe location, the chances that this lesion would be a malignant one would be more than 65%. PET and a non-surgical biopsy can help to decide whether it's a low or a high risk group. So what would be the approach? This is what would be the approach for the diagnosis and staging in patient with probable lung cancer? So any patient with a CT scan finding of a peripheral clinical stage 1 tumor with a clinical evaluation suggestive of no finding, there is no need of any imaging for extrathoracic staging. Only a CT thorax would be sufficed for intrathoracic stage, and we can directly go ahead for surgical resection. Similarly, clinically stage 2 patient with a or a central clinical stage 1 patients with no finding on clinical evaluation. For extrathoracic stage, we need a PET CT, and for intrathoracic staging, we need a mediastinoscopy or a EBUS. If it's negative, then we can directly go ahead with the surgery. These two would be discussed today, stage 1st and stage 2nd tumor, which would be early lung cancer. So what is the role in CT scan? It delineates anatomy of the lung. It uses 1 centimeter short axis diameter cutoff for malignancy. The sensitivity of CT scan is 51%, specificity of 86%. But important thing is that around 40% of enlarged nodes are benign, which was seen in CT scan, while 20% of normal size nodes contain malignancy. Because only cutoff for nodal metastasis is size, 1 centimeter more or 1 centimeter less, or less than 1 centimeter. So based on this, American Chest ACCP has given 4 groups of CT scan finding. Group 1, where the patient is presented with a peripheral tumor with normal hilar and mediastinum on CT scan. So N0 disease with a peripheral tumor. The chances of CT scan having the chances that the patient is having a mediastinum N2 disease would be around 10% for these N0 patients. Similarly, if group 2 patients were centrally located tumor and with ipsilateral hilar lymph nodes, so basically N1 tumor, the chances that the patient is having N2 disease is 25%. Similarly, if there is a discrete enlargement of the mediastinal nodes, but there is well-defined and non-bulky, they are well-defined and non-bulky, so N2 or N3 disease, there is a 40% out of 40% of enlarged mediastinal lymph node on CT will be benign, so leading to overstaging on the basis of CT scan. Next, 4th group would be an invasive, bulky, and conglomerate nodal disease, N2 or N3. CT is very reliable and considered a diagnostic of malignancy. So this is a CT scan. What is the role of PET in diagnosis? PET has a sensitivity of 74% and specificity of 85%. It can be inaccurate in up to 25% of nodes more than 1 centimeter. When we are doing whole body PET, in stage 1, the chances of picking up M1 disease is 7.5%. In stage 2, the chances 18%, and stage 3, the chances would be 24%. One of the biggest advantage of doing PET that it reduces futile thoracotomy. A futile thoracotomy is thoracotomy which is done, and after that the disease has recurred or patient has died within 1 year of surgery. Or a thoracotomy with pathologically confirmed mediastinal lymph node involvement, means stage 3rd A and 2 to stage 4 disease. A thoracotomy in a benign lung lesion, and an exploratory thoracotomy. So if we do 5 PETs, we can avoid 1 futile thoracotomy. What are the limitations of PET? So as we discussed previously, the 4 groups of CT scan, if we see the group 1 and if we do a PET CT, the chances that it give a false positive rate in mediastinum is 0%. while the chances of a negative mediastinum is 5%. False negative mediastinum is 5%. For group 2, the false positivity rate would be 15% and false negativity rate would be 25%. While for group 3, it will be 15% again false positivity and 25% false negativity for rate. For group 4, CT is considered a diagnostic for malignancy. PET may or may not require. So group 1 and in group 4, we don't need PET. For group 1 and group 4, imaging is adequate. So PET CT is adequate. We don't need invasive biopsy or mediastinal lymph node assessment is not required. But for group 2 and group 3, there is high chances of false positivity and false negativity. So we need a mediastinal biopsy for confirmation of our findings before going for surgery. There are multiple invasive methods for mediastinal staging, like traditional mediastinoscopy, video mediastinoscopy, video assisted thoracic surgery, transthoracic needle aspiration or biopsy, and recently endobronchial ultrasound with needle aspiration is also used. They have limitations in accessing the lymph node station as well. By the current standard, EBUS with needle aspiration is considered first investigation to be done if the mediastinal staging is required, and it has a false negativity rate of around 20%. So based on this, we can stage lung cancer. The staging would be done in TNM fashion. T1 is basically 3 centimeter or less tumor, which is in greatest dimension, which is surrounded by lung or visceral pleura, without bronchoscopic evidence of invasion, more proximal than lobar bronchus. It is divided into 1, 2, and 3. 1A, B, and C, less than 1 to 2, 2 to 3 centimeter, and T2 tumor 3 to 5 centimeter tumor. So today's discussion would be focused on T1, T2, and N1 tumor. N1 would be a metastasis in ipsilateral peribronchial and or ipsilateral hilar lymph nodes and intrapulmonary nodes, including involvement of direct extension. So if we see the outcomes basis on the AJCC 8th edition, the stage 1A1 has a 5-year survival of around 92%. This is based on clinical staging. 1A2 has a 5-year survival of 83%, 1A3 is 77%, 1B 68%, 2A 60%, and 2B 53%. So this would be our topic of discussion. The survival rate is around 50 to 90% from stage 2B to stage 1A1. So management of localized disease. Localized disease, there are two. There can be two ways. One is going curative local therapy first, like surgical resection or SABR, followed by adjuvant chemotherapy when the tumor size is more than 4 centimeter, or stage 2, stage 3A tumor. And there is neoadjuvant chemotherapy followed by surgical resection. Now it has been there is addition of neoadjuvant immunotherapy also followed by surgical resection. So as we discussed, only 20% of non-small cell lung cancer patients have early stage disease at the time of diagnosis, thus they are potentially operable. The recommended treatment of patients with stage 1st and 2nd non-small cell lung cancer is curative intent surgical resection. The current gold standard is lobectomy with hilar and mediastinal lymph node sampling or dissection. Type of surgery, we do know that lobectomy, pneumonectomy, wedge resection, they can be done. If we compare lobectomy with limited pulmonary resection or segmental or a wedge resection, we can say that the lobectomy is associated with segmental or wedge resection is associated with in 75% increase in recurrence rates, which attributes to around a tripling of the local recurrences, and it is also associated with 30% increase in overall death rate. So based on this, segmental resection or wedge resection is considered inferior. They can be done when a patient has a limited cardiopulmonary function. Similarly, if we compare lobectomy with pneumonectomy, there is a meta-analysis in stage 1 and stage 2 non-small cell lung cancer, which has revealed that lobectomy is associated with lesser mortality, 4.1% versus 6%, and there is no statistically significant 5-year survival rate difference, 51% versus 49%. So based on this, lobectomy is current standard of care or surgery for the stage 1, stage 2 lung cancer. Lobectomy again can be performed by either open surgery or it can be done by VETs or RETs. Recently, VETs has been used quite frequently, and there has been a meta-analysis which has suggested that VETs is basically associated with less intraoperative blood loss, less chest drainage time. It is associated with less hospital stay, and post-op complications are also less. And somehow it is also associated with a better 5-year OS rate, with a overall with a ratio of 1.82 in favor of VETs. Is there any role of Sbrt? Sbrt currently has not been tried in any phase 3 trial, but there are multiple phase 2 trials which has suggested that use of Sbrt can give 3-year local control from somewhere around from 88% to 98%. So it gives a good local control, but we also need to understand that these are mainly phase 2 studies, usually single arm studies. They have not been compared with surgery. There is one pooled analysis from the National Cancer Database where they have found that 3-year survival is around 55% with lobectomy, while it is only 29% with Sbrt. So based on that, Sbrt can be used in patients who are not fit for surgery or who refuse for surgery. Most commonly, Sbrt is used with a tumor of less than 5 centimeter size, but it has been used in some conditions where the tumor size is more than 5 centimeter also. There is one problem with Sbrt when using using Sbrt in centrally located tumor. Centrally located tumor means a tumor which is within 2 centimeter of proximal bronchial tree, and if it is abutting mediastinal pleura, they have been shown that if we use increased fractionations from around 4 to 10 fraction risk, the Sbrt can be safely delivered without undue complications. Now, what is the role of adjuvant chemotherapy? So, before 1995, multiple drugs has been tried as an adjuvant treatment for lung cancer, like alkylating agents, cisplatins, other drugs also. Then in 1995, there was a meta-analysis of 14 trials, which shown that the use of alkylating agents as adjuvant chemotherapy is actually detrimental for lung cancer management, early stage lung cancer management. It reduces 5-year survival by 5%. But if we use cisplatin-based chemotherapy, the 5-year survival increases by 5%. So based on this, multiple trials have tried cisplatin in doublet forms. For example, International Adjuvant Lung Trial, JBR10, ANITA, BLT. These all trial has stage 1, 2, and 3 lung cancer patients. Usually, ECOG stage 0 to 1. Majority had 0 to 1. And majority used cisplatin and vinorelbine as their chemo regime of choice. And majority of them has given a 5-year survival benefit of somewhere around 5 to 11% range. ANITA has given a 5-year OS rate of 51% versus 43%, and it has maintained till 7 years again. The difference was 8%. But if you see the results of ANITA trial, it has shown benefit only in N1 and N2 patients. N0 patient, there is actually a hazard ratio of 1.14. So it has shown no benefit for N0 disease. All the benefits were for N1 and N2 disease. After this all trials, there was a meta-analysis came, which is lung adjuvant cisplatin evaluation meta-analysis. These meta-analysis is suggested included 6 most important trial of that time. And it has shown a 5% absolute OS benefit, a 5.4% of absolute OS benefit at 5 years and absolute DFS benefit of 5.8%. But again, you have to understand that the hazard ratio for OS in stage 1A was 1.4. So it was actually detrimental. Again, Les also suggested that the effect was higher for better PS patients, 0 to 1 PS. Those patients has a higher benefit of giving adjuvant chemotherapy. Another important thing in this particular trial is that only vinorelbine containing cisplatin tablets has a higher cisplatin dose of around 300 milligram per meter square. Rest all has lesser doses of cisplatin. And if there is again, there was a subgroup analysis of cisplatin vinorelbine from that particular meta-analysis, and it has shown that a 5-year OS benefit is around 8.9% if we use cisplatin vinorelbine as adjuvant therapy. So based on these recommendations, till recent times, we were using cisplatin vinorelbine or cisplatin containing tablets as adjuvant therapy in early lung cancer. Now, recently, there has been a shift in the treatment of early breast cancer, early lung cancer, and that's because of use of TKIs, and second, because of use of immunotherapies. If we see the TKI trials, there are multiple trials with first generation TKIs, like one of those is CTOM. Other than that, Select, Radiant, where erlotinib was used. For CTOM, if we use gefitinib, the gefitinib is compared with vinorelbine and cisplatin, and primary endpoint was DFS. So there was no significant difference in OS. The median OS was 75.5 months versus 62.8 months in intention to treat population. There was a significant difference in median DFS from 30.8 months versus 19.8 months with a hazard ratio of 0.56. But because we are using this in adjuvant setting, we want OS benefit, which is not seen with the gefitinib. Similar results were seen with erlotinib also. Erlotinib initially was done in unselected population. In unselected population, erlotinib was associated with no benefit, no OS or DFS benefit. But when it was selected in EGFR mutated population, like in this population, there was a DFS improvement, but there is no OS improvement. But recently, osimertinib was used in adjuvant setting in early lung cancer in the form of ADURA trial, which is an international randomized double-blind phase 3 trial. It has included patients with completely resected stage 1B, 2, or 3A non-small cell lung cancer with negative margins. Primary non-squamous non-small cell lung cancer with EGFR exon 19 deletion or L858R mutation, age more than 18 years, and WHO PS of 0 to 1. The maximum time from surgery to randomization was 10 weeks without adjuvant CT, 26 with adjuvant CT. So these patients are 1:1 randomized into osimertinib 80 milligram till 3 years, or recurrence or discontinuation, versus placebo. Primary endpoint of the study was investigator assessed DFS in patient with stage 2nd, 3rd A disease, and secondary endpoint was DFS in overall population, and landmark DFS rate set year 2nd, 3rd, 4th, 5th, overall survival and quality of life and safety. So ADURA was associated with 83% reduction in risk of recurrence or death with osimertinib in stage 1 or 3rd A disease. Primary endpoint was basically this only, hazard ratio of 0.17 in favor of osimertinib. There is also 79% reduction in the risk of recurrence or death with osimertinib in overall population. So hazard ratio 0.91. If we see the subgroup of overall population, DFS benefit was seen in almost all subgroups with osimertinib, whether it's sex, age, smoking, non-smoking. Stage 1B has some lesser benefit, but rest all stages also had benefit. EGFR mutation and adjuvant chemotherapy, whether we are giving or not giving, the benefit was there. So it has shown benefit in almost all subgroups of the population. Next, another change in the treatment approach was the introduction of immunotherapy in the early lung cancer. First in the adjuvant setting, and then we will discuss in the neoadjuvant setting. There are currently multiple trials going on in adjuvant setting, which includes Pearl, pembrolizumab, Elvin, which includes nivolumab, durvalumab, and this is IM powered 0110, where adjuvant atezolizumab was also used in resected stage 1B to 3A non-small cell lung cancer patients after completion of adjuvant CT. So patients with completely resected stage 1B to 3A non-small cell lung cancer, tumor tissue for PDL1 analysis was required. The patient has completed adjuvant chemotherapy, cisplatin-based doublets, 1 to 4 cycles, and then they were randomized into atezolizumab 1200 milligram 3 weekly for 16 cycles versus best supportive care. Primary endpoint of the trial was hierarchical evaluation of investigator assessed DFS in 3 populations. Key secondary endpoint was overall survival in intention to treat population, DFS in stage 2nd to 3rd A, and PDL1 tumor cells more than equal to 50%. 3-year and 5-year DFS in all 3 population, and also safety analysis. So the first assessment of this, which was published as abstract in ASCO, has come out, and it has shown that there is a stage 2nd to 3rd A non-small cell. If you see, there is a the median DFS in stage 2nd to 3rd A non-small cell lung cancer with a PDL1 tumor cells more than equal to 1%. There is a hazard ratio of 0.66 in favor of atezolizumab. Similar benefit was seen with all randomized stage 2nd to 3rd A non-small cell lung cancer. The hazard ratio is now 0.79. The hazard ratio is also in favor of intention to treat population, which includes stage 1B to 3rd A, but the p-value is currently non-significant. Again, the results has shown that use of atezolizumab is associated with benefit in almost all subgroups, except the N0 subgroup, where it is almost equal, and ALK rearrangement status. So early OS data has come, and which is in favor of atezolizumab only, but it's still not mature. Next important thing is use of IO in NSCT setting. So what is the rationale for using neoadjuvant immunotherapy? So if we give immunotherapy in early stage, in NSCT stage, what the immunotherapy do is it basically suppresses the inhibitory microenvironment of the tumor. So that promotes T cell mediated immunity. So after the activation of diverse set of T cells, if we do the surgery, these T cells will go in systemic circulation and then will provide us the systemic benefit, systemic anti-tumor activity. As we all know that after surgery, majority of the recurrences are in distant sites only. So checkmate 816, where adjuvant nivolumab with platinum chemotherapy for resectable lung cancer stage 1B to 3A was used. It's a randomized phase 3 trial. Patients with newly diagnosed resectable stage 1B more than or equal to 4 centimeter size, 2 3rd A non-small cell lung cancer patients were included. There was no sensitizing EGFR mutation or ALK alteration was seen. They were randomized into 1:1 basis in nivolumab 360 milligram 3 weekly with platinum doublets 3 weekly for 3 cycles versus platinum doublet chemotherapy for 3 cycles. So then the patients were re-evaluated and radiological restaging was done, and patient went for surgery within 6 weeks post completion of chemotherapy. Then on the basis of histopathological reports, the patients received adjuvant CT plus minus RT. endpoint was pathological CR and event-free survival. Key secondary endpoint was overall survival, then the time to death or distant metastasis. Key exploratory endpoints were overall response rate, surgical feasibility, peri and post-operative surgery-related adverse events. So again, initial reports has been come as an abstract in ASCO. Oh, sorry, as an abstract, which has suggested that the pathological CR rate is 24% in immuno plus chemotherapy arm, while it's only 2.2% for chemotherapy alone arm. 83% of the patients in nivolumab and chemotherapy arm, while 75% in chemotherapy alone arm were able to undergo surgery. Out of those, 24% achieved PET CR in nivolumab and CT arm, while it's only 2.2% in chemotherapy alone. So out of these patients who underwent surgery, the pathological CR rate was 30.5% versus 3.2%. In intention to treat population, if we see the primary tumor only CR rate, it is 25% versus 2.8%. So in all subgroup, pathological CR rate was higher with use of immunotherapy. What are the toxicities? If we see in both the arms, majority of toxicities were grade 1, grade 2. There were few grade 3, grade 4 toxicities, especially pneumonia, which was higher in chemotherapy alone arm, but it is also seen in nivolumab plus chemotherapy arm. So, take-home points for this lecture: management of resectable lung cancer is rapidly evolving. Surgery alone is associated with non-satisfactory outcomes. Addition of chemotherapy improves outcome, but then more is required. For EGFR mutated cancer, osimertinib can be a game changer. And EGFR unmutated cancer, addition of IO in either NSCT or adjuvant form looks promising, but we need for more mature results. Thank you.
Thank you, Abhishek. Any comments? Kumar sir, your comment?
Nothing specific. Nothing specific. I hope it helped them. Who presented? Abhishek presented.
Yeah, no, sir, Rahul may present.
Rahul presented. Abhishek will present next.
Oh, sorry. So, any third year, any issues? Put your questions. So that we can take it up and answer it now, so that you get a hang of it. Maybe if you want, you can stop sharing, Rahul, screen. And yes. Any third year can ask questions. And that's why this forum was created, so that third year get a chance to clarify things for localized lung cancer, and we understand which part you want to have discussion, how to understand, what to answer.
So, sir, I have one question.
Go ahead.
Yeah, sir. When we are using, osimertinib in adjuvant setting, so currently there are very few relapses. But if the patient relapses, what will be the options, further options?
So, if there is a good gap, if the relapse after we have taken osimertinib has been stopped, then you can reintroduce if they relapse after 6 months or 12 months down the line. Your question is very pertinent in the sense that if they relapse while they are taking treatment, now that is a challenge, and that's an unfortunate situation, but that's a challenge. Then sure, we know that osimertinib has not been effective in these patients, and continuing osimertinib is not a good idea. doing repeat biopsy and then subsequent treatment will be important. This also creates a issue regarding if think about you had given chemotherapy and you started osimertinib and relapsed within 2-3 months. Now issue becomes, can we give chemotherapy also? So that again becomes a challenging. This will be uncommon, but enough number of patients if we start using osimertinib, which can challenge us what to do in this situation. Repeat biopsy, giving some molecular targets to treat them, yes, that is some fair option. Otherwise, we'll be ending up some chemotherapy which we have not given earlier, and combining with VEGF inhibitor. That will be early ones. Like if you have given chemotherapy, you started osimertinib and patient relapsing within few months. But if you have a bigger gap, then you can re-challenge with chemotherapy. If patient relapse on osimertinib and then have molecular testing. If they relapse after osimertinib has been stopped and then you have a 6 months or 12 months gap, you can again re-challenge with TKI. Osimertinib data we are waiting for, that I am not aware, but for gefitinib and erlotinib it has been done. And if there is a gap, then it appears the responses are similar. What we see otherwise the way we treat them first line. So if there is a good gap, then they do respond to a TKI again. So one of the concern that if you give TKI and there is a gap and the patient relapses, then we get resistant patients who don't respond. That may not be true, but the major challenge is that if they relapse early, then yes, we don't have much option.
Yes.
Akhil, do you want to add?
No, sir. Principally, agree with your comments, and definitely this is what we have learned from you, and our training has been like that. And so also the entire data is in favor of this protocol. It will be nice to see if we can pool the data of adjuvant osimertinib. A few of our patients have already received from Varanasi. I am sure there will be many from Mumbai. Then what we can do in the next line, that we'll need to see our own experience. That will, I think, that will take some more time.
This is a good idea to keep them in loop at this moment, and in due course, in a year or 2 years down the line, we'll learn it better. I agree with you, Akhil. We will try to do that. We'll try to see that can we keep the patients in loop whom we are giving adjuvant, and see that in due course, this small number also becomes useful in our learning. So next question by Venkatesh has a question that should we do molecular testing by default in all patients of lung cancer? Yes, in principle, I agree with him, except be careful that if you do testing in, for example, patient receiving chemoradiation, you may do the testing, but you may not treat the patient. But the reason for doing the testing will be that in case you do the test after 2 years or 3 years, if the patient relapses and you don't have adequate tissue, then the older tissue is not good enough. And new patients, you may not get tissue. For example, patient having brain mets, patient many times having only pleural diffusion as a relapse. So you may not get adequate tissue, and that time it becomes very tough to decide in these patients who can benefit with targeted therapy. So doing the test is important, but the importance of intervention will be different in different situations. In advanced stage, most likely you will intervene in the first line, some of them in second line. In locally advanced, you will not be giving those TKIs early. Let's see some data, some more data for it. At this moment, data is a bit iffy, but there is a promising data for erlotinib, but we don't give it. In early stage, yes, we do give it. Osimertinib is a great drug. Other drugs not as good as what we have seen with osimertinib, but in case you can give it in the patient with N2 disease and you can't give chemotherapy, then there is a merit to giving the first generation TKI also. So you do have a role for the testing in all these settings, but remember the roles are a bit different. So you are not able to give osimertinib, you have given chemotherapy, you may not give TKI, but the report of EGFR mutation will help you in when the patient relapses. At that time, without waiting a single day, you can start treatment. So, it is important to test, but merit is different in different situations. Venkatesh. In any other question by any other third year?
Sir, one more thing. When we are using adjuvant TKI, this gefitinib and other first generation has shown that there is improvement in DFS, but there is no OS. So, I mean, using osimertinib upfront would be a better option, or first generation followed by osimertinib would be a better option
In the adjuvant setting?
Adjuvant setting, yes.
So now, what has happened is osimertinib has not been compared with gefitinib in the adjuvant setting, but in advanced stage, it looks like osimertinib does far better, and that's what also we predict when we see the graph and you overlay the graph of osimertinib to gefitinib in any trial. Now gefitinib you have at least 3-4 trials. Looks like osimertinib appears far better. Other important aspect is that we are not certain after giving gefitinib and we give osimertinib, it will work or not. Because in case if you want to give gefitinib followed by osimertinib, and if you don't have T790M, then we don't know what happens to those patients. So 50% patients out of those window who can receive osimertinib. So that becomes a challenge. So at this moment in adjuvant setting, all probability, if you can give osimertinib, one should try it. But your question can be valid in some other context. There is also a trial with gefitinib by Japanese guy which didn't show DFS benefit also. So there is an issue regarding first generation TKI and the benefit of these patients, what they receive in adjuvant setting. So overall data for me is, if you can't give chemotherapy, end to disease, give first generation TKI. Otherwise, if you can get osimertinib, give it. But people also have tried giving in advanced stage setting alternative, give few months of gefitinib, few months of osimertinib. There is some basis to it, given this schedule, and it appears biologically, if giving this way of gefitinib plus osimertinib, it is not gefitinib followed by osimertinib, it is gefitinib plus osimertinib, but given sequentially during the time. So it is already mandated that every few months you give gefitinib and every few months you give osimertinib. And supposedly there is some synergistic effect. And there is a Japanese studies going on where they are doing this study. Let's see what's come out of it, and then maybe your comment may become more valid. But at this moment, osimertinib is feasible. Gautam asked the question, your opinion regarding EGFR TKI versus Sbrt in older patient with stage 1A lung cancer. A tricky one, expected from Gautam. So what do we know for Sbrt? So what we know for Sbrt in stage 1 disease, which is not fit for surgery. So what we know that it does an excellent local control. Almost majority of the patient, almost 80-90% of them, it doesn't fail locally. But they do fail around in that area, and distantly. So if you take the median survival of a relatively older cohort, which were given primarily Sbrt only in a patients where they were not fit for surgery, then the median survival of these patients has hovered around 25-26 months. Again, I repeat, don't take the newer series. I'm talking about older series. Hello. Yeah. Good one. Oh no. क्या होगा? ओह नहीं मैं करता हूँ बात उससे, ठीक है? मैं करता हूँ immediate ऐसे नहीं हो सकता, but मैं करता हूँ. Sorry, I got a call. I thought it was an administrative call. So it hovers around 25-26 months. That's what we have in early stage lung cancer for Sbrt. Now, second issue remains that if you are giving Sbrt to a patient with stage 1 where it is not fit for surgery, then most likely that patient has a lung compromise or other compromise. One of the issue with Sbrt remains that if you give Sbrt, immediately you don't have a complication, but as the time goes by, the surrounding structures who gets radiotherapy, they start showing changes. Because SBRT, we do know this as targeted therapy, EGFR is that means that it may be targeted, but doesn't mean it is absolutely safe. It doesn't happen like this. So that's a challenge with SBRT if it give in that situation. And in that context, Gautam wants to ask that can we give only TKI? Yes, if your colleague in today's time don't want to give SBRT, then you should consider TKI, not otherwise, because there is a merit to SBRT that you give in 4 or 5 days, in 1 week, patient goes home and you are happy about it. TKI does continue, but yes, it is a fair alternative, not a good alternative to SBRT. So SBRT stage 1B, I'll prefer it. Now, but there is a NCCN guideline, and I request everyone to read not stage 1A, Gautam, but wherever you want to give adjuvant treatment, the guideline suggests if you're giving SBRT, then adjuvant treatment option also remains the same. So yes, this is in general for TKI versus SBRT. Mishra ji had has sent a comment that can we start Gefapixant plus chemotherapy trial as an adjuvant treatment and it may improve DFS and OS. I totally agree with Mishra ji that in that trial it was sequential, and that is one of those questions regularly asked, can we combine it? And yes, I do feel that now there is no doubt about it, Gefapixant plus chemotherapy has a synergistic effect, and now we have a 4 randomized trial in literature in advanced stage setting. So there is a merit to it. There is a merit to it to do this. Any other question by any student? Rahul, Abhishek, Minit, anyone has any question or on early stage lung cancer, which we reviewed today, which you think exam point it will be useful? And I request fourth year to pitch into put those questions so that and also answer together. Okay, these are the questions which can come in. But in the meantime, yes, third years can keep asking questions.
Hello, sir. Sir, I want to ask.
Go ahead.
Yeah. Sir, I want to ask about the soft indicator of adjuvant chemotherapy. We consider a chemotherapy patient who is a visceral pleural involvement. So after adjuvant, what benefits seen in the both patients who had a soft indicator for adjuvant chemotherapy?
Can you repeat the question?
Sir, I want to ask about the soft indicator. We consider this a visceral pleural involvement. Yes, sir. So what benefit we found, sir, after adjuvant chemotherapy for those patients?
Okay. So Abhishek is asking about data. So usually, we have by and large followed the hard indicator only to give adjuvant chemotherapy. But your question is right, that if you have patients who is less than 4 centimeter, and then you have those high risk features like you have poorly differentiated carcinoma, you have a tumor which has got lymphovascular invasion, if you have a margin which is close or positive. In all these situations, if we give those adjuvant chemotherapy, what is the benefit? So, I also tried to search that part, Abhishek. I haven't got that, but I think so. My feeling is where it has come from is that one is that outcome is poor for these patients, and these were the patients all included as part of the trial, and that is where I always suggest that it was a subgroup analysis which suggested that these group of patients don't benefit, means that less than 4 centimeter, they don't benefit. And that is what has led to not use of chemotherapy in less than 4 centimeter. But also people did realize that less than 4 centimeter is not one group. You have a various subgroup into it, and are we really certain that none of them they benefit? And that is what has led to having that as a part of a treatment option in this setting. So if anyone can quantify how these subgroup benefits, no, Abhishek, as such that outcome is poor in these patients. That is certain about these patients in this setting. And just now, Vijay shared with me regarding different sizes and also what kind of benefit they receive in the individual risk group of these patients between 3 to 4 centimeter patient, and that does suggest that you do get hazard ratio 0.8 for lymphovascular invasion, for high grade around 1.04, more than 2 or more than 2 risk factor around 0.96, sublobar surgery 0.72. So again, suggesting that you do have some suggestive benefit in this situation. Again, I repeat, I don't mean to say this is the only way to treat every patient, but think about if I have a patient with of 3.5 centimeter, poorly differentiated carcinoma, lymphovascular invasion, sublobar resection, then I will be concerned. I will be using it. If I have only a patient with 3.5 centimeter and to use it adjuvant chemo and all other parameter not being there as a high risk, most likely I won't use it. So this is the way we use the software indicator, in our clinic to use, chemotherapy. Abhishek.
The amount called 2020 में paper है ये 50,000 patients का analysis एक बार पढ़ लेना अभिषेक.
Or we'll share with you. एक बार भेज देंगे ये अभिषेक, so one can go through it. But I'll say for the exam purpose, this is for learning purpose in the practice. For exam purpose, keep it simpler. More than 4 centimeter adjuvant chemo, less than 4 centimeter, keep it no. But if a examiner discusses further, then you can discuss it further. Okay?
Yes, thank you.
Any fourth year wants to share their experiences of the exam so that they can put those questions for the third year? I can see Lakhan here, Prahlad here. So anyone wants to share so that they go get those hang of it, what is usually asked?
Good morning, sir. Lakhan here, sir.
Hi, Lakhan. Some tips for the exams for the third years?
Sir, as you have sir already covered most of the parts, sir, which are being asked, and the third years have also. Just I want to say that whenever we usually at most of the time get the advanced cases in the exam only, but however, as we have the development and we have the treatment option which we had used in the advanced and the locally advanced and even in the early cases also. So even if we have the case of the advanced, it is still that our viva, and they ask usually the pertaining question which is applied to the non-metastatic part also, such as the DORA trial. And when these trials are asked, I mean, when we are being asked the benefit of this trial, we must have the we must go through that trial, and we should be able to answer them with the because these are which have shown the significant benefit. So if some of these trials which have shown in the benefit in the locally advanced setting, that we should be well read with that trial, and if any question is asked to that, we should be able to answer that also. And per se, the Viva usually starts with the advanced cases with the approach only, and after the approach, the most of the part it is discussion on the treatment only. So this today's talk, that will be a very helpful, and we should go with that approach only, sir.
So Akhil, any some pearls for them?
So the key to success and key, everybody will succeed, that is for sure, but the key remains to keep calm and not to go into areas where you have less knowledge. We have learned from Kumar sir and other seniors also that if we it is the student who drives the discussion. The student can drive towards any side. So if you are not well versed with in a particular topic, it is better to say something related and then tell, sir, I'm not confident on this topic, or you can say some mild words, and then this will shift the gears. Else, if you give wrong answers, you will go into deep side of wrong side. So that remains the key. That is from my side, sir.
झगड़ा मत करना एग्जामिनर से, उस दिन एग्जामिनर इज राइट.
Okay. Anyone? Anything else? Anyone wants to share, and anyone wants to suggest some tips? If not, then back to Akhil. Akhil, back to you.
Okay, sir. Then we can conclude.
Thank you.
Thank you, sir. Thank you.
Thank you, sir.